Welcome to my YouTube channel. Today we are going to talk about COPD. So COPD is a disease that is characterized by persistent airflow limitation, that is bronchodilator, that is FEV1, and FEV ratio of less than 20, that is not reversible. So let me explain this first statement. So uh, chronic uh, chronic obstructive pulmonary disease. This is a disease that presents with airflow limitation. That is one thing you have to note. However, there are also other diseases that present with airflow limitation, including asthma. So for us to differentiate between asthma and COPD, what we do, we give a bronchodilator. And then we measure EV1 and FEVC before giving the bronchodilator and afterwards. So if the bronchodilator in FEV1 and FEV1 and FVC improves after the bronchodilator by greater than 12% or greater than 200 ml, then that means it is reversible. However, if the ratio still remains less than 70% or 0.7, then that means it is irreversible. So COPD has two features, or it has two diseases in it, that is chronic bronchitis and emphysema. So chronic bronchitis is defined by its clinical features, that is chronic or recurrent cough, which has a lot of sputum for most days for minimum of 3 months a year, at least for 2 successive years. While emphysema is defined by structural characteristics or changes, which is a pathological diagnosis of permanent and destructive enlargement of air spaces distal to the terminal bronchiole without obvious fibrosis. We are going to see more of this. So there are several epitypes of COPD, and the epitypes of COPD are following. It could be genetically determined COPD, that is alpha 1, alpha 1 antitrypsin deficiency. This meaning if its deficiency was there still since birth, meaning it is age of onset is younger compared to the other one, which is, for example, COPD, which the major risk factor is it's smoking, which will develop in obvious elderly patients, and hepatic signs such as jaundice, hepatitis, and cirrhosis. So COPD due to abnormal lung development, this is when the patient is premature birth, low birth weight, among other neonatal problems. In addition to that, we also have environmental COPD, as I've mentioned before. This is cigarette smoking, which is one of the big risk factors for COPD, biomass and pollution exposure. We also have COPD due to infection, that is when you have childhood infection, TB associated with COPD, HIV associated with COPD. We could also have COPD and asthma occurring in the same patient, and COPD of unknown cause. So, as I've said before, we'll look at the subtypes of emphysema, which we said is a pathological dilation of the terminal bronchioles. So we have three types. We have centrilobar, we have panlobar, and we have paraseptal. So centrilobar is the most common one, and it's seen mostly in smokers. It is characterized by destruction of the respiratory bronchiole. That is the central part, and it is first the distal part, and it mostly affects the upper lobe. So for you just to remember this, we'll just say, so when you smoke is more of hair. So air in a room, if for example, if you're in a room and then there's smoke, hair will go up. So it affects the upper lobes. This is an example of the central lobar or acina, which affects the central part of the acina. Panlobar, it's rare and associated with alpha-1 antitrypsin deficiency. It is characterized by destruction of the entire acina and respiratory, and it affects the lower lobe. So just to think of this, I think I've just understood this, right? As you said in the previous slide, that alpha-1 antitrypsin also affects the liver, and the liver is almost below anatomically, the liver is inferior to the lungs, so it affects the lower lobe, just as a method of recalling. So this is the panlobar, which it affects the entire acina. And then the paraseptal, it is when it affects the distal part. This is rare. So the risk factors, as you already mentioned, is tobacco, which is 90% of the cases. His host factors, you already mentioned, that's the genetic factors, which will already have them from at birth, that is alpha-1 antitrypsin deficiency, abnormal development, as you have said, of the lung. This is due to low birth weight, premature and childhood respiratory infection. In addition to that, we also have environmental factors, that is occupation dust, vapor, fumes, gases, or biomass. Especially when a woman comes in your clinic or in your hospital, then the first, and you're suspecting this disease in your history, then most probably you get that the woman has been using the fuel of the traces biomass over the years. and also other is chronic asthma. So for the physiology, in COPD, there is airflow limitation in the small airways, and it's caused by three mechanisms. The first one is loss of elasticity and alveolar attachment due to emphysema. As you have said, emphysema is the dilatation, and then this reduces the elasticity recoil, and there is and the hair collapse during expiration. So let me just explain. So when you breathe in, the lungs expand, and when you breathe out, the lungs uh, recoil, they come back. So when you lose this elasticity that helps us in breathing in and out, so during expiration, then our airways will collapse. I hope this is just really understandable. The next is inflammation and scarring of the small airways, and it causes them to narrow. The next is mucus secretion, which blocks the airways. So each mechanism narrows the airways and causes hair trapping, leading to hyperinflation of the lung and breathlessness. So even in an X-ray, we are going to see the hyperinflation of the lungs. So in addition to the lung of the pulmonary effects of COPD, we also have systemic components where you have muscle weakness and cachexia. This is due to the inflammatory markers, that is the C-reactive protein, TNF, interleukins. All these have catabolic effect on the muscle and the bone, and this patient will actually look like cachexic. This patient will look like a cancer patient. In addition to that, we also have cardiac deconditioning. Obviously, you know, when a lung is affected, what will be affected next? Cardiac. In addition to that, you can also have syndrome of inappropriate ADH secretion, which will have impaired salt and water excretion, leading to peripheral edema. In addition to that, we already said weight loss, and we already explained the pathophysiology behind that. We also have osteoporosis. This is due to poor mobility and inflammation, which will the inflammation will activate the osteoclast and suppress the osteoblast. In addition to that, we also depression, because this patient is suffering most probably, for example, if it is due to smoking. This is a self-inflicted disease. Then chronic COPD also leads to chronic respiratory acidosis with metabolic alkalosis as the compensation. This is normal acid-base balance. So what are the signs? What are the signs? I want us to start here. Chronic cough. And this cough, kindly note that this cough is productive. So unlike the cough, for example, in asthma, which is dry, we also have cyanosis, we have prolonged expiratory time, which I've already explained, use of accessory respiratory muscles, and sometimes if it's chronic or for a long time, you can also have some signs of pulmonary, where you have edema and morning headaches. You can also have wheezing, breathlessness, tachypnea, and tachycardia. So these are symptoms. So signs on auscultation, you'll have end expiratory wheezes, and you also have decreased breath sound, which is typically quiet. You can also have inspiration crackles. You may or may not. So on percussion, as you've said, this is hyperinflated of the airway of the lungs. So you'll have hyperresonance, non-specific findings and symptoms. So kindly note and kindly note and kindly note. When you see clubbing, it's not a feature of COPD. So you'll have to look for other features, for example, bronchiectasis and fibrosis and lung cancer, among others. So you must exclude lung cancer and fibrosis if clubbing is present. As I've said, finger clubbing is not a feature of COPD and should trigger further investigation for lung cancer, bronchiectasis, and fibrosis. So diagnosis. Obviously, from diagnosis, if you are new here, or for example, if you're not new here, you've always been here, you know our diagnosis, even if it comes from an exam, what we start with is history and examination. And then you label what are the specific history and examination findings in COPD. Next is spirometry. This is the first thing that I explained, and spirometry, I said in COPD, you'll have airflow limitation. And when you have airflow limitation, what will you airflow limitation is also found in which diseases did I say we have in COPD and asthma. So when you have in COPD and asthma, then you have to do you have to give a bronchodilator. So you do post bronchodilator and before pre bronchodilator. So pre, it will still be reduced by 70%. But when you give a bronchodilator and it's still reduced by 70%, then this is just indicative of then COPD. So next we screen for alpha-1 antitrypsin deficiency, chest imaging, which we're going to talk more about, and then CBC. So this is more of a chronic. Actually, in its name, it's COPD is chronic. So if it's chronic, then you'll have secondary polycythemia. This is because these are the adaptive changes. So if our lung have this problem, and our lung enables us to get oxygen in our bodies. So what will happen? Our bone marrow then will end up producing more WBCs, which will have secondary polycythemia in addition to increasing muscle rate. You can also have ECG in advanced cases where you have left ventricular hypertrophy, and also screening. So in screening, the goal that is the global initiative of COPD recommends screening of asymptomatic patients and adults with spirometry, patients who are undergoing annual lung screening with low dose CT, and patients who find incidental findings of COPD. So patients who have been, for example, they're coming for annual lung screening, and then you use with them you do low dose CT. Then in addition to that, you also do spirometry. Or in patients when you're just doing an imaging and then you find incidental finding of COPD. So as you said before, we are going to talk more about the chest X-ray findings. So signs of pulmonary hyperinflation. If you can just see here, this is it. I really don't know what to say. So increased anteroposterior diameter, which gives a barrel chest, as you can see, and pushed down and flattened diaphragm. It's evident here. Horizontal ribs and widened intercostal spaces. You can see here. Hyperlucence of the lung and decreased lung markings is all over in this chest X-ray, and long and narrow heart shadow. Yeah. Long and narrow heart shadow. So this the GOLD, that is the Global Initiative for Chronic Bronchitis. They have the classification according to FEV1 and FEV3 ratio. So the grades, we have grade 1, grade 2, grade 3, and grade 4. So grade 1 is mild, where we have the FEV1 is greater than 80% predicted, and then grade 2 we have 50%, and then grade 50 to 80%, and then grade 3 where we have severe, where we have 30 to 50, and then grade 4 where we have very severe, less than 30 FEV1. So these are the 4 grades of COPD. So next we will look at the MRC dyspnea score, and 0 is when person is kind of normal. We only get breathlessness upon strenuous activity or exercise. 1 is when they get short of breath or dyspnea when hurrying on a level ground or walking on uphill. 2 is when on level ground I walk slower than people of the same age because of breathlessness, or I have to stop, check a breath when walking my own pace. 3, I have to stop for a breath after walking 100 yards or after a few minutes on level ground. 4, I am too breathless to leave the house, or when I'm breathless when dressing. So the gold grades and the MRC, in addition to assessment that is graded, it's used to develop the ABC assessment score, where you have to do the spirometry confirmed diagnosis. You assess the airflow limitation and obstruction, as we have said, and assess the signs and symptoms and the risk factors for exacerbation. So we have A, B, and C. So A is where you have an MRC score of 0 to 1. You have after you've done the assessment, you have greater than 10. It has scored greater than 10, and 0 to 1 moderate exacerbation not leading to hospitalization, history of exacerbation. And then B is where you have a great MRC grade of greater than 2, and the assessment test is greater than 10 or equal to 10. And also you have 0 to 1 moderate exacerbation not leading to hospitalization. However, when you have a history of leading to hospitalization that is greater than 2 moderate exacerbation, or greater than 1 or equal to 1 leading to hospitalization, then you have E. So those A, B, and E are important in terms of diagnosis and also treatment. So diagnosis, so differential diagnosis, you also have the number 1 is asthma, number 2 is chest X-ray. So asthma, you obviously distinguish the symptoms vary day and night, which are worse at night and early in the morning. And chronic heart failure, you do a chest X-ray, you'll have dilated heart, you'll have pulmonary edema, and then you'll have volume restriction but not airflow obstruction. Bronchiectasis, the patient will have large purulent sputum and bacterial infection, and in an image you also see bronchodilation. So TB, it will give you a picture of also pneumonia, which will have lung infiltration, microbiology, then you have to confirm through microbiological confirmation. And then those are just the rest. And then management, so you have the goals for management. They are divided into two, where you have to reduce the risk, the reduce symptoms, and you reduce the risk. So in terms of reduction of symptoms, you have to relieve symptoms, you have to improve exercise tolerance and improve the health status of the patient. And in terms of reducing the risk, in terms of disease progression, prevent disease progression, and prevent and treat exacerbation and reduce mortality. So management of COPD, obviously after you have done diagnosis, symptoms, risk factor, and spirometry, then you do an initial assessment. In terms of initial assessment, as you have said, FEV1, where you grade into grade 1 to 4, as you have mentioned before, and then using that using symptoms, that is the CAT and the MRC, and exacerbation history, then you grade, as you have said, A, B, and E. In addition to that, smoking status, blood eosinophilia count, anti-alpha-1 trypsin, and comorbidities. Then after that, now you start the initial management. That is, you help the patient stop smoking. Vaccination, we are going to talk more about this. Active lifestyle and exercise. Initial pharmacological management, self-management education, such as risk factors management, inhaler technique, breathlessness, and written action plan. In addition to, you manage the comorbidities. Then, just as asthma, you remember in asthma when you were talking, we used to say you assess, you adjust, and you review. So you assess, you adjust, and you review. So you adjust both pharmacological and non-pharmacological therapy, and when you review symptoms again, just as assessment, and you also do the CAT and MRC, exacerbation, smoking, exposure to other risk. How is the patient using the inhaler, and how are their adherence? How is the physical activity and exercise? Do they need need for pulmonary rehabilitation, self-management, and then need for oxygen? Do they need non-invasive ventilation, lung volume reduction, or palliative approach, vaccination, and management of comorbidities, in addition to spirometry? So we are going to just go through the management as we have discussed. You identify and reduce the risk factors. So if it is smoking, you help the patient in terms of smoking cessation and effective ventilation. If, for example, the patient is using biomass, among others, and polluting cooking stoves. So in terms of vaccination, I want, if you are given a question, you're told, give me 3 vaccinations that you need to vaccinate a patient who has COPD. You have to say, number 1, influenza, number 2, COVID-19, and number 3, pneumococcal. In addition to that, you can also give a respiration syncytial virus vaccine in patients who are greater than 60 years and or patients who have chronic lung disease and also heart disease. In addition to that, you also vaccinate against whooping cough or pertussis. In addition to that, you also vaccinate against shingles in patients who are greater than 50 years. So next is the initial pharmacological therapy. So in terms of the initial pharmacological therapy, you already categorize the groups into A, B, and E. So in terms of A, and exactly the way we categorize them is just here. So in patients who have 0 to 1 moderate exacerbation not leading to hospital administration, and whose MRC scale is 0 to 1 and the CAT is greater than 10, you just give a bronchodilator. But in patients who are B and who have moderate 0 to 1 to moderate exacerbation not leading to hospitalization, and patients who are MRC score greater than 2 and or CAT greater than 10, then you give a LABA and a LAMA. However, in patients who are in group E, they have greater than 2 exacerbation or 1 leading to hospitalization, you consider LABA, LAMA in addition to ICS if the eosinophil greater than 300. So follow-up. So in terms of follow-up on the pharmacological treatment, if the response to initial treatment is appropriate, then maintain. So if the patient is improving in terms of situation, then maintain. If not, you check their adherence. How is the patient using the inhaler? Is it do we have possible interfering comorbidities? Then you consider the predominant treatable trait target. So is it dyspnea or is it exacerbation that is disturbing us? So in case where we have both, we use the pathway for exacerbation. Place the patient in a box corresponding to the current treatment and follow the indication. So you reassess, you assess, you adjust, and you review. So in terms of dyspnea, if the major complaint is dyspnea, then you give the patient LABA or LAMA. So if the patient is not improving, then you add on a LABA and LAMA. Consider switching inhaler, device, or molecules. So implement or escalate non-pharmacological treatment and investigate and treat for other causes of dyspnea. So if the major problem is exacerbation, then you give LABA or LAMA. So if the patient, and then in addition to that, you check is the eosinophilia greater than 300. If yes, then you do LABA, LAMA plus ICS as mentioned before. So if eosinophilia is less than 300, then you do LABA and LAMA. So if eosinophilia is also greater than, it's LABA and LAMA is not working, or you don't have appropriate treatment, and eosinophilia is greater than 100, then you give LABA, LAMA, and ICS. If it's less than 100, then you give then if it's less than 100, then you can, there's add-on therapies where you have Rumilast and erythromycin. So this is PPD antagonist. So non-pharmacological management of COPD. So we have grade 1 and grade B and E. So in terms of grade A, smoking is very essential. So you have to help patients in terms of smoking, and you also recommend physical activities. In addition to that, we said influenza vaccine, COVID-19, pneumococcal hepatitis, shingles, and RSV. In group B and E, smoking cessation including pharmacological treatment, where you help the patient in terms of bupropion and the exercise in terms of quitting the smoking. You can also help in terms of patches, among all those. In addition to pulmonary rehabilitation and then physical activities. The vaccines are mentioned here, which is influenza virus, vaccination, COVID-19, pneumonia, pertussis, shingles, and RSV. So drugs that do research, they have been shown to help reduce mortality are number one, oxygen, 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 oxygen. If there is oxygen, oxygen, oxygen. So the rest are just which have been shown to also help in terms of number one, smoking cessation, pulmonary rehabilitation, lung volume reduction surgery, in addition to LABA, LAMA, and ICS. But oxygen, oxygen, oxygen. So notes on bronchodilators. Inhaled bronchodilators are the mainstay in treatment and regular basis to prevent and reduce symptoms. So they are always recommended over oral bronchodilators. Why? Because slow onset of action, they give systemic effects. That is the oral bronchodilators. So SABA and SAMA are superior to when they are used alone. So if you give SABA compared to when you're giving SAMA and SAMA, this is the combination is better. Also, the combination of LAMA and LABA is also superior to the single drugs alone. LABA and SABA are preferred over the short-acting drugs, except in dyspnea and relief of immediate symptoms in patients on long-acting. So next is the long-acting drugs improve lung function and dyspnea and reduce the risk of exacerbation. LAMA has a greater effect on exacerbation reduction and reduced hospital stay compared to LABA. So anti-inflammatory therapies are drugs which have been shown to have anti-inflammatory effect. They include ICS. The regular treatment increase the risk. So ICS, in terms of, you just don't give any patients who has COPD ICS, because regular treatment will increase the risk of pneumonia, especially patient with severe disease. So LABA, LAMA, ICS is superior to and is recommended over LABA plus ICS. Patients with asthma features obvious, where you hear asthma, ICS has to be present. Oral glucocorticoids are not recommended because of the long-term effects such as osteoporosis. The phosphodiesterase 4 inhibitors, these are the ones like Romilast, we have talked before. This is used in patients with chronic bronchitis and severe to very severe COPD. Antibiotics, as we have talked before, long-term azithromycin and erythromycin also reduce exacerbation. Mucolytics such as N-acetylcysteine are also important in terms of helping in COPD. So factors to consider when initiating ICS, this one we have just already talked about. Strongly factor. So issue of hospitalization for exacerbation of COPD. This is when to use when you have greater than 2 or equal than 2 moderate exacerbation per year, and when your blood eosinophil is greater than 300, or where you have history of concomitant asthma. So where you hear asthma, ICS. So favor use where you just you just use where you have moderate exacerbation, one moderate exacerbation of COPD per year, and when you have eosinophilia of 100 to 300. However, against use where a patient has come in with a repeated pneumonia events and blood eosinophilia is greater than 100. Also, when you have increased mycobacterial infection. So complication of COPD, you can have respiratory failure, which is the most common. You can have pulmonary hypertension and constriction, and which will lead to pulmonary. This is because hypoxia constricts the pulmonary arterioles, which increase pulmonary resistance. When it increases pulmonary resistance, what we have? Pulmonary hypertension. When you have pulmonary hypertension, then it will exert more pressure on the left ventricular, which will later hypertrophy, and then later will get right heart-related heart failure. You can also have pneumothorax, which is not very common, where you have, for example, the rupture of the emphysema. You can also have acute exacerbation, which is mostly due to infection or non-compliance. Extrapulmonary, as you have said, cachexia and osteoporosis. In addition to that, you can also have bacterial colonization, which will later have bronchiectasis, among other factors, and also said secondary septicemia and hemoptysis. Thank you.